So Ron, if you're ready, then I'll start sharing your slides.
Thank you very much. Yeah, we are ready. Maybe that Frans can give a very short introduction about himself so that we also know who is Frans.
Yes.
Yeah, sure. So my name is Frans van Amtel. I'm as my name is already making clear, a Dutch person with a long history in market access. I started my career many years ago in Switzerland, where I worked for Novartis, setting up the pharmacoeconomic department. Then I spent a few years working for WHO as a regional advisor of pharmaceuticals for the European region. And I'm back in the Netherlands since about 20 years. Have been working with Ron for the last 15 years, focusing on market access of pharmaceuticals, medical devices, and health technologies. My background is in public health and health economics. And what we typically do is look at new health technologies from an early stage on, and supporting these health technologies in their long or less long road to achieve reimbursement, not only in the Dutch market, but we have a European and American organization. So what we typically do is help organizations who don't have market access capabilities by themselves to establish market access, pricing, and reimbursement tracks in many countries at the same time. And in that team, Ron and I focused on Netherlands, Belgium, Luxembourg, and of course my colleagues from other countries on their respective markets. So the advantage we have is that in all of the European markets, we have in-market expertise to actually support the process of pricing and reimbursement in all these markets. But as you know, in the EU, the subsidiarity principle applies. So each country has its own healthcare system. And that means that when the clinical track has been arranged in all these markets, the pricing and reimbursement needs to be arranged separately.
Okay, thank you. Thank you very much. Yes, I will start with an explanation about, we call it the Dutch ecosystem. So as we didn't know exactly who would attend, I'm going to talk about the Dutch healthcare system in general. And besides the text on the slides, I will tell you a lot of other things during this session. So listen well and write down if you want to write down some issues, and please ask questions if something is not clear or you want to know more. We will start for the next almost 2 hours. So let's go with the first slide. Yeah. We normally start with mentioning the Dutch laws which are in charge. We have the House Insurance Act, the Long-Term Act, the Social Support Act, and the additional insurances. These are the 4 sources where the money is coming from. So you don't have to know these laws, but you have to bear in mind that different laws are in charge, and each law does have other responsibility. In a way, the Zorgverzekeringswet, Health Insurance Act is for the care, the Long-Term Care Act is that's for the care, the other one is for the cure. Social support is for people in the home situation we are in need of help, and additional insurance, that is a separate business from the health insurance companies. But bear in mind there are different laws which are very important for the people, of course, who work and offer services in the Netherlands, because in those laws is more or less decided what you have to do or what you don't have to do. May I have the next slide? As said also in the earlier presentation, no reimbursement, no market. We know that, of course, all the people in the Netherlands are fully insured, and insurance companies are paying for everything. So if something is not insured, people think, okay, that's no good healthcare. So otherwise it would be insured. So if you have a not reimbursed product, it will be very difficult to sell, and especially when a reimbursed product is available. Then people prefer a reimbursed product above a non-reimbursed product. That's logical. We have to make a distinction between two product lines. One, we see that there are investment products. Companies make CT scans or other products like that, and that are sold to institutions like a hospital, a GP practice, or whatsoever. And this is paid from the budget they have, of the money they have, and nobody cares about where they buy, what to buy, how they buy. This is calculated in the price. So if you deliver an investment product, you only have to do the business with the buyer, and that's it. On the other hand, we know that there are a lot of products. It is related to an individual person, a knee and hip, and a medicine, and other medical devices. This is something that is on a person's name, and that is to be insured in a certain reimbursement code. So the insurance companies are paying for this based on the invoice sent for this product for this patient. Well, that is the difference. It might be that some investment products are maybe expensive and only used for only a few patients. And if these patients are also named by person of people, it is just for him, then it might be that, for example, a hospital wants to have a special price, a separate price for this service or this product. So then you also need to do something to have it reimbursed. So that is then, it is bought from the budget, but they want to have some extra money, and that's possible in our system. May I have the next slide? Yeah, I'm going to explain a little bit how it works in the Netherlands. In all the laws we have mentioned in earlier slide, there's nothing written about what healthcare is. Healthcare is a black box. What is healthcare? We in the Netherlands have said that healthcare is what the doctors think is healthcare. So the professionals themselves decide what healthcare is, and that is insured, or that could be insured. We call it the standard of care in daily practice. If a product or a service is according to the standard of care in daily practice, then it is insured, and then the patients are entitled to have this. So you don't find in the law exactly what is healthcare. You're entitled to go to the hospital, to have an operation, to have a bed, to have food, to have a nurse. No, that's not mentioned in the law. You go to a hospital, you get the healthcare you need, and that is insured. And that we call is the standard of care in daily practice. So healthcare products or services has to fulfill all the requirements of the standard of care in daily practice. And where can you find the standard of care in daily practice? That you can find in all the guidelines which are published by the organizations of doctors, by the scientific organization, where you can find what will happen with you when you cough and you have a certain indication. What will happen with you when you have this? Then you can read what they are going to do. So that is the standard of care in daily practice, and that is reimbursed healthcare. Bear in mind that if something new is coming to the Dutch market, it has to fulfill all the requirements, but we have a lot of healthcare in our system already 20, 30, 40 years, and nobody asked any question. It is just, it came in the healthcare, it is reimbursed, and nowadays people are wondering, why are we reimbursing? What does it do? Is this also according to the standard of care and daily practice? Especially our government is willing to discuss about this, because they might skip a lot of healthcare due to cost reasons. But today, if you come with something new, and Frans will later on explain you exactly how the procedure will go, it has to fulfill the requirements of standard of care and daily practice. May I have the next slide? Yeah, and then is the big question, if the doctors decide about what healthcare is, then almost everything is healthcare, and that doesn't our government want. So we have created an institution, it's called ZIN, the Healthcare Institute Netherlands, or the Health Advisory Board, however you name it. And that organization decides if new healthcare is according to the standard of care and daily practice. So you have to submit to them to ask, is it according to the standard of care and practice, and is it reimbursable? And ZIN can give an opinion and say, yes, this is okay. Or ZIN can also say, no, this is not okay because you do not have enough evidence, you have the wrong evidence, we don't believe it, etc., etc. But ZIN is the institution in the Netherlands who decide, yes, this is reimbursable or not reimbursable. And in the daily practice, we see that especially insurance companies always have doubts about if something new is offered by the doctors. The doctors are telling, yes, it is according to the standard of care and daily practice. Insurance companies have their doubts because they have to pay, and then both parties go to the ZIN and ask, give an opinion, is this reimbursable or not reimbursable? And that's why we are telling to companies who come with a new product, ask first for an opinion of ZIN, so that the party who is delivering your product knows that it is reimbursable and that you don't have problems in the discussions with insurance companies. Okay, may I have the next slide? And then we have another institution in the Netherlands, also paid by the government. It is the Dutch Healthcare Authority. So if we know that the doctors decide about healthcare, the ZIN gives an opinion, yes, it is reimbursable, then you still need something in the system to be able to invoice. And to be able to invoice, you need to have a code. The Dutch Healthcare Authority is responsible for giving the codes, so it's also quite a procedure. And the Dutch Healthcare Authority is able to decide, yes, we give a tariff. And it can be a free tariff, a fixed tariff, or a maximum tariff. And a free tariff will say that for that product and that code, the provider, the healthcare provider, and the insurance company can negotiate about the price. It's completely free, but you have to negotiate. So you can set the price in the negotiations with the insurance company. If the product is so rare and only a few providers can offer this product, let's think about certain operations is only done in 1 or 2 hospitals, then the Dutch Health Authority is afraid for the competition that they fixed the tariff. They said, okay, it is one fixed tariff and that's it. We decide about that. And they can only charge that fixed tariff. And then we have also the so-called maximum tariff that will say that it is free negotiable between the healthcare provider and the insurance company, but it is a maximum. So it may not be higher than the maximum, but always lower. In the daily practice, we see that the max is still the price. Nobody goes lower than the maximum. So you have to understand that the Dutch Health Authority is responsible for coding and pricing. And free pricing will say that the healthcare provider, the hospital, is able to negotiate with the health insurance companies about prices. So that is the system. ZIN and NZA are separate from the government, but they are government paid and they do all the things what the government wants, what they have to do in the healthcare system. We have the next slide. If we look to the 3 laws, Zorgverzekeringswet, WLZ, WMO, these are the laws where the money is coming from to pay the healthcare which is offered by the healthcare providers. May I have the next slide? A little bit about the Health Insurance Act. That is compulsory for everybody who is living in the Netherlands. Of course, the government decides about what it is. Costs you some money, you pay a certain premium per year or per month to the health insurance company plus a percentage over your income. What we know in the Netherlands, 70.5 million people on average, that 70% of the people are insured in so-called collectivities. They are working in a company and the company makes a contract. They are a member of a certain organization and they have a certain contract. 30% is individual insured. And what we see, and I explained that a little bit later, that the policies is that 50% budget in kind, 20% mix and 30% reimbursement. And I explain the difference in a few minutes. Yeah, it is compulsory, but you are able to change of insurance company each year. And we see that about 1 million people change each year from health insurance companies. And that makes our system very complex because 1 year you're insured with Achmea, the next year you're insured with Mensis, and the other year you're insured with another insurance company. But the problem is that your disease or when you're in hospital doesn't stop on December 31. It's also on January 1 or 2, but then you're insured with another insurance company and then there's a problem who's paying for you and etc. So that's one thing. And the other problem is the administration, because 1.1 million people needs to have a letter, goodbye, you change of insurance company, we will see you never back again. And they also sent 1.1 million letters to people, welcome in our insurance companies, and this is our policy. So it is a lot of administration business, but okay, it is our system. About 84% of the people does have an additional insurance that is offered by the insurance companies, and that is for some extras which is not insured in the basic insurance. And think about dentistry, some other therapies which are not in our normal system, and that is for the additional insurances. And that is a completely private market. Okay, may I have the next slide? The WLZ is nothing to do with insurance companies, but with health offices. And we have the so-called health offices in the Netherlands. There are 32 health offices, and those health offices are negotiating with the institutions who are delivering the care. There's also a completely different business that are budget discussions, etc. And yeah, different worlds with different rules. The funny thing is that the health offices are located and part of the health insurance companies. So health insurance companies are also performing the activities of the health offices, but there are two different worlds. So it's typical Dutch, two different worlds, but it is one organization who is responsible for it, the health insurance company. Okay, the next slide. The Long-Term Care Act. Now, long-term care, also income-based contribution. You see it is a different way how to get the money. So you don't pay a premium directly, but it is all over your income. And we have 32 regional health offices, complete different world. Yes, the next slide, please. Then we have for the social things, we have the municipalities who are responsible. I will explain a little bit later about what that is, but a lot of healthcare medical devices are paid for by the municipalities. And we have a lot of municipalities in the Netherlands, a complete different way of doing business. And this is the only market where tenders are mandatory, because municipalities are public and they need to tender, but I will explain that later on. Next slide, please. Now, all kinds of social support, medical devices, 352 municipalities funded from local taxes, and they use tenders for the WMO. You don't have to deal with 352 municipalities. Some municipalities are working together so that you have maybe some 150 to 200 contact points to negotiate, but that will be shown later. Yes, next slide, please. Now, we're going back to the Health Insurance Act. There we see that we have health insurance companies with Achmea, CZ, Mensis, VGZ, and some others, smaller ones. Those four insurance companies have about 90% of the market, so they are big parties. They are regionally very strong, so Achmea in the west, CZ in the south, Mensis in the east, VGZ middle and south. They are dominant in the market, and it's very difficult to meet them, to contract them, but okay, they are responsible for the health insurances and for the contracting activities. There are a lot of brands in the Netherlands, but at the end of the day, they are all private labels from the big four. So you think, oh, what a competition in the Netherlands, what a health insurance companies, but nice pictures, but it's the big four who are delivering healthcare under many, many private labels. Okay, next slide, please. That we have already seen, you may go to the other one. Yes, how does it work with health insurance companies? Now, we have two kinds of policies. Benefit in kind, the health insurance company contracts the healthcare provider. Think about a GP, a pharmacist, a hospital, a physiotherapist. The patient does have a contract with the health insurance company, and the patient is allowed to go to the healthcare provider with a contract with the health insurance company. Then it is completely reimbursed. The patient doesn't see an invoice. The invoice is going directly from the healthcare provider to the health insurance company, and that's it. If a patient does go to a non-contracted healthcare provider, then he has to pay the invoice himself, and he will be reimbursed for about 70%. So there is a penalty for going to a healthcare provider without a contract. So in a daily practice, we see that patients are going to the healthcare providers with a contract. And in that situation, the power is at the health insurance company, because they own the patients and they are negotiating on behalf of 1 or 2 or 3 million patients, depending, of course, of the insurance company and the number of insured people. But they are having the power in this situation. The other situation, and on the right side, is that the health insurance company and the patients does have a contract, so-called reimbursement policy. The patient is looking for the healthcare provider of his choice. That healthcare provider sends the invoice to the patient sends it to the health insurance company, and he is reimbursed. So about 30% of our population preferred the right one, but it is a little bit more expensive, not so much, it's a little bit more expensive than the other one, but health insurance companies want to get rid of this situation because they don't have power. They have only to deal with the patient, and the healthcare provider has nothing to do with the health insurance company. So that is the difference, and that they don't want, of course. There's one insurance company in the Netherlands who is only offering this kind of policies, the ONVZ, about 400 to 500,000 insured people, and it is preferred especially by people who know healthcare and can make their own choices. On the left side is more for people who doesn't care about where do I have to go. I ask my insurance company to take care for it. So that's also a little bit of difference. Okay, the next slide, please. Yeah, who contract who? That's always for people coming from abroad a question. How do I get to the health insurance company? In the daily practice is this way. The manufacturer, he contracts a distributor. The distributor contracts the health insurance company. And the health insurance company doesn't contract the manufacturer. That is a little bit changing, but in the daily practice today, manufacturers doesn't have contacts and also no contracts with health insurance companies, the distributor. And who is the distributor? No, pharmacy, a medical supply shop, even a GP can be a distributor, and also hospitals are distributors. You sell to a hospital, that the hospital sells his services to an insurance company. So he is also, a sort of distributor. Don't tell it to a hospital because then they are a little bit angry, but okay, they are distributors. And if you have seen in the slide here before, that in a situation that the health insurance company is contracting the healthcare provider in that benefit in kind system, it doesn't contract each provider. They say, okay, if I have contracted from the 70 hospitals, 50 hospitals or 60 hospitals, that's enough for my insured people. Or I don't need every pharmacist, I don't need every medical supply shop, so I make choices. So it can be that some people, some healthcare provider doesn't have a contract and are not able to deliver to the people with the benefit in kind policies because then they have an own co-payment of 30% that they don't want. So in that situation, health insurance companies are very powerful. They say, I don't need you. Then you have a problem. Also, a manufacturer can have a problem in that way. If he delivers to a distributor without a contract, but the distributor can't deliver to the insured people, then the manufacturer doesn't have to deliver to the distributor because there is no market. So it is very important to understand how that works. And if you talk with the distributor who will do the distribution for you, do you have contact with health insurance companies? How did you arrange that? Are you anyway contracted? Okay, now that is part of our system, that at the end of the day, the health insurance company has to pay. And he is having his power, and he is using his power in the negotiations. Today we see sometimes that manufacturers can have direct contact with an insurance company, but he is not to be seen as a distributor because there are distributors in the market. But the contacts are then about, can you give a discount if I decide to have your product reimbursed by delivered by the distributors and reimbursed by us, then I want to have a certain discount. We have in the organization of health insurance companies, they have an umbrella organization. And in that umbrella organization has created a team. They call it the clean team, unbelievable, but they call it the clean team. And this team is negotiating with manufacturers of medicines, especially, but nowadays also with manufacturers of medical devices about, you are charging this price. Can you explain me why this price is as the price is? And I don't agree with this price. I want to have a discount and all these kinds of things. And then you're in a situation that you have, of course, to give a discount to your distributor, and the other day you have to give a discount to the health insurance company. Now, there is your margin going. So be aware in the situation that you have to give discounts to almost everyone in the Netherlands, and no, that can't be the situation. This is the system, how it works. Okay, next slide. Yeah, then is it reimbursable? The Dutch Health Institute, ZIN, is having some questions before they make a decision. Yes, this is reimbursable. Is there a health problem that matters? Of course, otherwise we don't do it. Is there a solution that really works? Can you prove that? Are the costs reasonable in relation to the health gain? Cannot this cost be paid by a patient himself? Good question. That's also depending, of course, of the burden of disease. There will be a trend in the future that the patient, of course, has to pay more himself than now because we can't afford it anymore in the system. And can society do this? Yeah, society has more cost these days about the COVID pandemic problems, about all those problems we know today. But okay, these are the criteria that has to be answered before the decision can be made. Yes, we are going to reimburse. Frans will talk later about this, but then you have a little bit an idea what you can expect. The next slide, please.
We do have a question.
We have a question. Perfect. Who?
Hi, Frederick here. I just have a quick question. It's actually on the previous slide on when you talked about who contracts who, and I'm just wondering, for a diagnostic company like us, would labs play a similar role to distributors, or where would you place a laboratory in this in the value chain in that sense, in terms of who contracts who and who actually provides the test?
There are two labs. We have labs in the hospital. They are working in the hospital, and we have labs on the street. Now they're not really on the street, but when a GP asks for a certain lab, then he can send it to a lab, a commercial lab. There are some different commercial labs in the Netherlands. And there is also a list produced by the NZA, a tariff list that each lab needs to use. So all those tariffs are decided on the national level. So it is not negotiable between the lab and the insurance company. The insurance company has to reimburse the price which is set by the Dutch health authority. So that's the situation. What's happening today is in the labs in the hospitals are more or less to be sold these years. So a lot of labs of hospitals are sold to European chains of labs like Eurofins and all those kinds of organizations. So we see that it is also being more commercial, and that only the change will finally have the market of labs in the Netherlands. Labs in hospitals are working for the hospital, of course. Then you have the labs outside of the hospitals, and there you send to by the GP or sometimes also by the medical doctor in the hospital. They send you a form. You go to a lab. They take the samples, etc., and the invoice is sent to the insurance company, and they are paying according to the tariffs. And it might be, and it happens that some labs doesn't have a contract with an insurance company, and then they can't invoice because it's also a commercial market. Yeah.
Okay, great, thank you.
Okay. Then we go back. Yeah, this is all these issues will be discussed by Frans, and efficacy, cost effectiveness, budget limit, burden of disease, quality of life, key opinion support, patient organization support. He will talk a little bit about that, what you have to do, and that's why I want to have the next slide. Patient organization support. We have noticed that in a lot of countries in Europe, there are no patient organizations. In countries like Germany and France and the UK, there are no real patient organizations, but we do have them in the Netherlands, and they are very important. They are private, of course. They also fund a lot of research. So if you are looking for research, then you can have a contact with a patient organization. They do grants, investment, have a good key opinion network. But nowadays, patient organizations are becoming also a little bit powerful in the discussion about reimbursement. It is needed when you're coming with a new innovative product also to have an opinion of the patient organization. And if they say, no, we don't like it, then it will be quite difficult to have it also reimbursed in the Netherlands. So it is becoming more and more important. And I think we have so many patient organizations, I think about 30 or 40 or maybe more. Almost for each disease, you have a patient organization. And if you're able to contact them, they have contact with key opinion leaders. They have contact with hospitals and doctors. And often they have an advisory board where you find the important people of that market. So if you, for example, take heart disease, they have an advisory board where all the important doctors are a little bit connected to. So if you can't find them directly or talk directly, try it via a patient organization. And they are open for discussions. It is just the public, it's patients. So it's a good thing. I don't know in Sweden, do you have patient organizations over there?
Yes, we do. But since we're not reimbursed in the same way that in the Netherlands, maybe I would say just by listening to you, they have a stronger power in the Netherlands.
Even though they do fund quite a lot of research.
Yeah.
Yeah, okay, we see sometimes in the additional insurance that if you are a member of a patient organization, you pay a certain fee. That fee is also reimbursed. So they stimulate indirectly to be a member of a patient organization. So that's the situation. Okay, next slide, please. Now, coming back to the basic package for the Health Insurance Act, what is insured in that, according to the Act? Medical care, GPs, hospitals, hospital time, dental care, medical devices, medication, maternity care, patient transport, paramedical care. It's all in the basic package of the Health Insurance Act. So if you are delivering products for this kind of markets, these kinds of healthcare providers, then you have to deal with the Health Insurance Act. Next slide, please. Long-Term Care Act, that is for the vulnerably elderly, disabled people, full-time care, unable to live independently in their own home, etc. That is the Long-Term Care Act. So if you are delivering products which are meant for this market, then it is the Long-Term Care Act and the institutions. Next slide. This is also in the Long-Term Care Act, all categories. Now, you know them all. Maybe after the next slide. Social Support Act, municipalities are responsible also for people at home. A lot of products are able to sell to the municipalities for people in a home situation. It's also depending, of course, of the local policy and who are responsible, but we see that there are a lot of possibilities, and if people know the way how to do it, they will get it from the municipalities because it is local. People know each other, and that's it's very important to understand. And how do municipalities do the business? They have to tender when the amount of money is enough to tender, and they don't tender on a product, but they tender on a distributor. So they ask a distributor who is able to deliver all the products which I have to deliver to the people in my municipality, and he will have the contract. So if you're coming with a wheelchair, they don't contract wheelchairs as such, but they contract a distributor, and the distributor delivers wheelchairs and all the other products. So if you want to sell to a community, to a municipality, you don't go to the municipality, you have to go to the distributor who has the contract with the municipality. So that's how you do the business. And that is a little bit typical, but it is the way it is. Sometimes, if a distributor doesn't want your product because he's having other products, other interests, you might go to the municipality and have a good story. Said, listen, they don't want to have my product, please, etc., etc. Then you can have sometimes also a deal with a municipality without a tender. So that's possible, but always the situation, do I know the people, where do I have to go, etc., etc. Okay, that is about the WMO. Next slide. What's in the WMO? Shopping service, meal service, domestic help, etc., etc. So there's a lot of activities which are paid for by the municipalities. And remember, it's all paid in the local taxes. So if a municipality spends too much money, then the people have to pay a higher tax. It's also not always a good story. Okay, next slide, please. Care for the elderly. We have nursing homes. More than 600 nursing homes, 80,000 people staying in nursing homes. It's a huge market. It's paid for, fully paid for according to the Long-Term Care Act. Home care, almost 4,000 institutions, from very big ones to very small ones. Also 2 persons can have an institution for the home care. So it is a weird market, but okay, it exists. Rehab centers, we have about 140 institutions in the Netherlands. Rehab centers are also budget finance, a lot of possibilities, a lot of money is available for the rehab. Next slide, please. A little bit about reimbursement for the home care. If you deliver products for the home care, it is a system that, depending on the severity of the disease of the person, of the need of the person, it is from 1 to 10. If you're 1, you get less. If you have 10, you get a lot of. It is possible that you can have the services and that you don't have to pay for the services, so more or less in kind. But you can also have a so-called PGB, personal budget. Then you get the money, and then you are responsible to spend the money for the right care. And a lot of people in the Netherlands do have a PGB so that they can make their own choices. I don't want to have the help from the institution, but I want to help from another institution. That's why there are so many home care institutions, because it's a huge market. People with the PGB are able to make their own choices. And if you are local, then you may choose for a local institution instead of a big one. So no, that's why the market is as it is. Next slide, please. No, you can have it, the care in an institution. In the institution, then everything is paid for you because you are completely in the institution. So all the products, medicines, medical devices, the dentist is paid by the institution. So you can do the business with the institutions. They have their own budget based on the people and the severity, of course. And you can also have the care at home. Now, then the only thing is it may not be higher than when you are staying in an institution. And you can have the full package, or you can have also still the PGB, the personal budget. And that's beloved in the Netherlands. On the other hand, there is also to be seen there's a lot of fraud with the personal budgets, that companies are delivering healthcare, but not delivering, but charging the money, but people doesn't know. And okay, a different market, but okay, it exists. And if you are delivering products or service for the home care, yeah, be aware how it works and what you can do, and then how your clients have to work with that, because you are delivering to them and they are delivering to the patients at home or in the institution. Next slide. General practitioners, GPs. I've seen in the products that we have been discussing at the start that some of you may face or may have to deal with the GPs. We have 12,800 GPs in the Netherlands in about 5,000 practices. We have set a norm that a GP on average has 2,095 patients. That is his income on base. The GP gets a fixed fee on a yearly base for the fact that he is a GP and he is having his office or his practice. And each person in the Netherlands needs to be written or inscribed, how do you call it, needs to be known and also part of the practice. So that you ask a GP, can I be in your practice? Yeah, you may be in my practice, and then the GP gets the money from the insurance company each year. If you change of GP, very difficult because there's a shortage of GPs, so you can't not so easily change of a GP. Then also the money is not going to the old GP, but to the new GP. So you're bound to the GP. Each year you can change, but it's very difficult. And if the GP, if you go to the GP, he can charge a certain amount, a consultation fee. If the GP comes to you, then he can charge it almost double the fee, and that's it. So that's why in this situation that the GP gets the money for the patient, and it might be that he doesn't see the patient in a year and that he still gets the money because he's having his practice and he is there for you. And if you're not coming, okay, he still gets the money. But there's also the situation that when the GP gets the money, he doesn't want to see you because he gets the money. So in this situation, the GP will send you quite soon, quite quick to the hospital and say, okay, difficult problem, please go to the hospital. Because for a consultation fee of 10 euros, he is not willing to see you the whole day, morning, and complaining, etc. Go to the hospital. So he's referring you quite quick. But okay, that is the system. It is as it is. A GP, yeah, not paid so very well. It's about 150,000 euros brut income in the Netherlands. They're working quite hard. Next slide, please. He's the gatekeeper, because you need to go to the GP to be able to go to the hospital. You need to have his referral. If you want to have medicines, you need to go to the GP and you need to have his referral. The same situation with medical devices. Also, not, yeah, for the first time, you need to have a referral. And if it's a chronic disease and you need it forever, then you don't need a referral again for the devices. But for the medicines, you always need a referral, even if it is chronic. So that's all done online or by the GP practitioners who are helping the GP, etc. But he's the gatekeeper. And as said, GPs used to send the patients quite quick to the hospitals. And in the policy, we want that the GPs are doing more themselves. And to trigger them, yeah, we have to pay. So we have developed a system in the Netherlands that if the GP is doing more, he can get more. And we have the so-called M&I rates, modernisering and innovatie. And S3 rates, that's also a technical term, that if the GP is doing somewhat more and it prevents the patient going to the hospital, then he can have the money for that. And we see that a lot of new activities can be done in the GP practice. And think about more activities on testing instead of going to the hospital, more activities on surgery, so-called minor surgery, activities also with diabetes patients. We have also new programs. We call it the GLI, Geïntegreerde Lifestyle Interventie, Integrated Lifestyle Intervention. Are activities where there's also a certain specific rate for developed by the Dutch Health Authority to stimulate the GPs to do more, preventing people to go to the hospital because hospital is expensive. So if you have products which enables the GP to do more, and if it is possible for the GP to create an extra tariff or more money, then he might be interested. But also bear in mind that if you offer this product, you have to do all the activities to enable him to have more money because he doesn't have time, he doesn't know, and you know, etc., etc. So it is not that the GP is coming to you, can I have your product so that I can do this? No, you have to go to the GP, and if I give you this, you can do more, and I take care that you will have the extra tariff. So that's the way, a little bit how it works. And we have a shortage of GPs, also due to the fact that all GPs are working part-time. So if you need a GP on Friday after 12 o'clock, it's very difficult to find one. Then you have to go to the first emergency care in the hospital. And they start sometimes in the Monday morning. Yeah, in former days it was 24 hours available, but that's not anymore. Part-time, workload too high, we need more GPs. So if you can deliver GPs to the Dutch, there is a market for that. Next slide, please. We have pharmacists.
Ron, sorry, may I interrupt? Just to understand, do you then, if you're a company that wants to facilitate the GPs, you have to stay in touch with each one of them?
The last, what is your question?
So if you want to, if I change back to the other slide, if you try to provide the MNI or S3 rate, do the companies have to be in contact with the GPs one by one? I can't hear you now.
Yeah, he's open again. The GP needs to contract a health insurance company for an MNI or an S3 rate. But the GP doesn't have the time, he doesn't know how it works, so you should help him to do this kind of work, this kind of activities. And if you have developed an MNI rate or an S3 rate in a certain region, then also other GPs can make use of that. So when it is developed and it is agreed on, then each GP can use the same rate on MNI or S3 with that insurance company, because each insurance company can decide, yes, we are doing or we are not doing. So, but if one insurance company did it, and other GPs who are working also with that insurance company can charge the same tariff or under the same code. So that's how it works. But in the daily practice, what we see is that GPs do like to do it, but doesn't have the skills and know-how to develop this and to discuss with insurance companies. And you have to help them. And if you ask Frans later, we are doing such a project. We're doing different projects with that. And we have to do almost everything. We have to write the letters, we have to make the calls, we have to prepare this, we have to prepare, basically, yeah. The manufacturer wants to have the product accepted, but we have to do all the things because the GP is too busy. Sophia, with a question.
Yes, it's very interesting that you say that the GPs, obviously they have a shortage of GPs in the Netherlands, we all know that, but do you have a sense that a similar kind of development is underway in the Netherlands that we've seen in Sweden in the past few years, that more and more general practitioners also adopt digital tools to triage, manage caseload, manage communications, to be able to help more people in the same time?
Yes, yes, we see that there are also, if you want to meet a GP, they first try to do it with a telephone call or with a video call or whatsoever, so that you don't have to come to the practice, that we see this kind of activities. I don't know if it is very well developed. It could always be better, but it's also depending, of course, of the patients. Some elderly patients want to see the GP live. If I want to make an appointment with my GP today, I probably can be there next week Tuesday, because this week is already full, and then I have to wait a few days. Unless it is immediately, then I can go immediately, but with a normal question, I have to wait some time. That's how it works today. So I think that there is a lot of improvements to be made. I do think so, yeah. Okay, the pharmacies. Now, they are still important in the Netherlands because they are responsible for delivery of the medicines to outpatient people. We have almost 2,000 pharmacies in the Netherlands, but 590 are in a chain, Benu, VNA, Alliance, Medicine. They own pharmacies. We have 1,100 working in a formula. That will say they have a certain common brand, and they have together developed leaflets, etc., all those kinds of things. And Mosadex is also a wholesale company, and Fluripharm is also a wholesale company, but they have a certain developed formula. And yeah, a lot of pharmacists are working under that formula. So you think that is a service apotheek, but it is still independent, but you're working with Mosadex. And we have real independent pharmacies, so only 200. Pharmacies also delivering medtech, like incontinence, ostomy, diabetes, and also some other products, but it is not the main thing. That is, medicines is the big market. We have a lot of discussions in the Netherlands about generics because they are cheap. Parallel import is also used by pharmacies because we have often a shortage of medicines in the Netherlands. Maybe the same problem exists in Sweden, I don't know. But we have developed a system that generics do have a very low price. Our insurance companies themselves went to India to negotiate with manufacturers over there for cheap prices. Only 10% of the 100% before, so it is very cheap. And they say to the pharmacists in the negotiations, you have to deliver generics for this price, because for that price you can buy it in India, so we are not reimbursing more than that. Now you can imagine that all the prices went down, but nobody wants to deliver because the prices are too low. So they deliver the drugs, the medicines, preferably to Switzerland, France, and Germany, and not to the Netherlands. So we have often shortages of medicines. And then the medicines are bought in other countries, in Greece, in Portugal, and in Germany as a parallel import and coming back in the Netherlands, also rather low prices. So it is a very competitive market. And that's done by the insurance companies. The insurance companies decide every 3 months, I think, or every month, I'm not exactly, about the preference package. So these medicines are we reimbursing for this price, these brands, and that's it. And this is changing almost every 2-3 months. And for patients, it's very difficult. Today they get a green pill, tomorrow a rosa pill, and then a red pill, and then a blue pill, because the brands are always changing. And it gives us a lot of rumors. But that is a big discussion in the Netherlands. We want to have it cheap, but we also importing problems with cheap prices. Okay, next slide. Reimbursement for pharmacies, they get a prescription fee. Now you can see here the prices, what they get. The medicines which are reimbursed are in the so-called GVS, medicines reimbursement system. And we have the so-called A and B list. And the generics are in list A with a maximum reimbursement price. And under that maximum price, insurance companies are negotiating lower prices. And we have unique medicines where there is no competition and they have a free pricing, but also a limit that the government decided the price may not be higher than the average of 4 or 5 countries. So we have a price regime on medicines in the Netherlands set by the government, but also negotiated by the insurance companies. So not a good market to start. Pharmacies are not doing well. In former days, they were good companies. You could earn a lot of money, but today it's bad business. That's why a lot of pharmacies are sold to chains, the chains of wholesale companies. They are the owner of the pharmacies. Okay, next slide.
Ron, may I jump into the question again?
Yeah.
Have you seen, it's on the same theme as Sophia, have you seen it in Sweden? There's quite a lot of digital pharmacies. Is that also trending in the Netherlands, that they don't have necessarily a shop, you buy online and get home deliveries?
No, it's not so well developed. We see it in other way because we have not so huge distances like in Sweden. We have almost in every street a pharmacy. No, that's not true. But what they are doing today is that for your medication, they have a sort of robot machine in the wall. So you get a telephone message that your medicines are ready. You get a number. With that number, you go in the machine and you get your medicines. You don't even see the pharmacy anymore because you don't have to enter. You can take it out 24 hours. But that we see, and we do not have a very well developed post-order, mail-order pharmacy. It does exist, but it is not so well developed because the insurance companies only reimburse when you go to a pharmacy with a contract. And if you go to a pharmacy and the mail order pharmacies doesn't have contracts with the insurance companies, or not so many, so then it is not reimbursable. So nobody goes to a mail order pharmacy. It doesn't exist. We do have a mail order pharmacy in the Netherlands, well developed, but for the German market, because it was forbidden in Germany for a few years to have mail order pharmacy. But when it was sent from the Netherlands to Germany, it was allowed. So the Germans set up companies for mail order in the Netherlands for the German market and not for the Dutch market. No. It's Europe, it's possible. Yes? Okay, then if somebody is willing to do something in the dental market, of course we have dental care, but only for younger people it is reimbursed, and for the adult people you have to pay yourself, or it is the additional insurance. We have about almost 10,000 dentists, oral hygienists. They are quite old, all, and we expect in the next years that there will be a lot of people leaving the practices, so we will have a problem. Today we have already 15% it's coming from abroad, from Germany, from Spain, or wherever from. We have 4,800 practices. The chains are also coming. We have chains like Dental Clinic, Dent Connect, and all those beautiful names. Also, it's all private equity, but it's developing. 3.1 million in 2020, billion is that. So, yeah, it's still some money ongoing in the market. But what we have seen here, you have to pay yourself, but the NZA made a tariff list with maximum prices. So the dentist is only to charge the codes which are set by the NZA and the prices set by the NZA. Because the NZA and the government thinks that the dentist is misusing the situation. When a patient is in the chair with some pain and he wants to help, and then you can charge everything. So is that we set the prices, it's not a free market, and that's it. So even for non-reimbursed healthcare, the prices are set and the codes are set. It's not a free market. Okay, so do understand that the government does something in the Netherlands to prevent high prices. Next slide, please. Hospital care, 61 hospitals. This is really a difficult discussion. Until 2003, we had a system that the hospitals negotiated about a certain budget, and they took the budget and that was it. And it was quite a black box because they got the money and what are they doing for the money? And nobody knew. Now, in 2003, we introduced the Dutch DBC, a sort of DRG, introduced the DBC system. And we created in the Netherlands 40,000 DRGs. And it was the intention that hospitals would negotiate with health insurance companies about 40,000 DRGs, about prices, quality, volume, etc. Of course, that didn't work, so it was decided to reduce the number of DRGs to about 4,000. But behind those 4,000, there are still 40,000 DRGs, and they expect that there will be negotiated about this DRG. Now, that doesn't work. So what is the system? The hospitals negotiate about an annual budget, like they did before 2003. And the annual budget is invoiced by the DRGs. So they agree with an insurance company a certain budget for this year or for next year. They plan together what kind of DRGs are you going to deliver, and we can talk about a certain price of the DRG because the DRGs are making the budget. We are going to do so many heart operations, we are going to do this, we're going to that. You calculate everything together, then you come to a certain budget. But in our system is that the budget is the budget. The insurance company said, this we agreed. It is also due to the fact that the government said, we may not grow in cost for the hospital, so it is a zero situation. So each year it will be more or less the same amount of money which is available for the hospitals. So they agree a budget, and when the budget is reached, then it is over. And then we have two situations. That one situation, especially for the weaker hospitals, they have contracted with the insurance company that they will deliver the healthcare until the end of the year, but they don't get money for it. Or the stronger hospital said, when the budget is over, my service is over because you're not paying anymore. So that's the situation. And we always see at the end of the year that some hospitals said, we are not closed, but we have a fairly long waiting list. So I advise you to go to another hospital. They are in a situation that the budget is already in and they deliver no healthcare because they don't get money. But we see also the situation, it was 1 or 2 years ago, the hospital said, I don't take in patients from that insurance company anymore because we have reached the budget. Please find another hospital, goodbye. And that's the situation. So we are talking about DRGs, and I explain a little bit later what is a DRG in the Netherlands. But it is used to calculate, it is used for the negotiations, and it is used for invoicing to the insurance companies. But if the budget is reached, it's over. And then you can do a lot of work, but it's not paid for anymore, or you don't do the work, and that's the situation. And that's why we always think in September, October, okay, if you want to go, you need to go to an hospital. Be aware if that hospital is willing to help you. And in that situation, you see also that the negotiations between health insurance companies and hospitals are very important, so that you know, okay, they do have enough money to treat me, or they don't have enough money anymore to treat me, where do we have to go? Now, all those kinds of things are happening. Very nice to know. And also, when doing business with hospital, you have to understand their problems with insurance companies. Okay, that's the hospital. Also, that there are a lot of DBCs which are free negotiable, but also with fixed prices, fixed by the NZA or with maximum prices, also NZA decisions. Next slide, please. I'm looking to the slide. Now, in the DBC are all the costs, and in the DBC exists of a lot of codes. We call it care activities, and each activity has an own code, unless it is part of an investment good. It doesn't have a code. Minor things, the food is not in a code, the bed is not in a code, the nurse is not in a code, but a lot of other activities are in a code. And what in a code is to be calculated and to be seen, and that is part of the DRG. And what is the situation with medicines? Medicines doesn't have a code. A hospital buys the medicine. Unless the situation that there are expensive medicines and that hospital said, no, I want to have more money because for this patient I'm using this expensive medicine and I want to have more money. That's possible, but it's a complete procedure you have to follow to get the extra money. So that is difficult, but okay, it's to be done. For medical devices, we do not know expensive medical devices. There are, of course, but we do not know them. So there is no extra money for expensive medical devices. But what they do is that they try to have a code for certain medical devices so that they are able to negotiate with insurance companies. We are using these medical devices. Okay, look at the code. We have done it so many times. We want to have extra money. So they use it to negotiate extra money. So that will say that we have medical devices without a code. They don't see it anymore, and with a code. And you always try to have a code in the DRG because then you're visible, then they can negotiate, and then they can have extra money for it. So if you're coming with a new device for a hospital, the first question is, do I need to have a code? Okay. Then, is there already a code? Because there is maybe a similar product already having a code. Can I use that code? Yes or no? If not, but I still want to have a code, then you have to do a complete procedure to have a code. And about this procedure, Frans will talk. How do you get a code to be able for the hospital to charge the money for that activity and that product? Okay. Is always a question of whether the new thing to be introduced needs a code or whether it can use an existing code. If a code is needed and no code exists, the whole process of market access with SIN and SZA will have to be gone through. Frans will explain. Then doctors in university hospitals are on a fixed salary, and the other doctors in the general hospitals not. They have their own business. They are more or less self-employed. So they are more interested in new activities, being able to have more business or to do more activities, etc. So medical doctors in general hospitals work 24 hours a day. Medical doctors in university hospitals, 8 hours a day maximum. So that's the difference. Okay, next slide. Hospital care, DBC care products. I explained it a little bit. Care activities. You can read it. Next slide. I'm looking at the time. Next slide, please. Then, with your medical device, this is really a weird thing, but it's almost the end. You have a medical device and you have your market authorization and you want to have it in the DRG in the hospital. Then the first thing is there a code? Yes, there is a code. You can use the code reimbursement opportunity. No, there is no code. Then you have to do an application with the NZA for a new care activity, a new code. The same question, the question also will be, is this reimbursable? Do you have enough evidence, evidence-based medicine, EBM? Yes, we have enough evidence, then it is also a reimbursement opportunity. A code and standard of care and daily practice based on the evidence-based medicine together makes it reimbursable. Now, if you have to go for a code, is the NZA, then the ZIN will also involved. Because they have to do something about, yes, it is reimbursable, not reimbursable, patient organization is involved, scientific organization of doctors is involved, the whole circus is coming in. It might be a situation that you don't have enough evidence yet, because your clinical studies were not okay or not finished yet, or the publication is not done yet. Now, then you can wait till everything is ready, but we have some loopholes in our system so that you can still have some money and temporarily code and temporarily reimbursement without having enough evidence, but still being able to look for the evidence and still being paid. There is budget in hospitals. It can be case by case. We have guidelines for innovation to have extra money. We have the conditional admittance. All those possibilities give you money and that you're able to do business. And besides that, there are a lot of other black boxes to work with so that an hospital is able to do the job and to charge the products. Interesting is, of course, case by case, because if a case is done 2-3 times and reimbursed, and 4, 5, 6, 7, 8, and 9, and 10 are also done. That is in a way, the guideline for innovation is negotiation between hospital, health insurance company, the Dutch Health Authority, etc., etc. So do understand that we have a formal system, but there are a lot of other possibilities to have the products introduced and reimbursed. So don't be afraid. There is always a solution. Otherwise, there is no innovation in healthcare. Next slide, please. In the outpatient market, so medical devices prescribed by the GP. Now, sometimes the hospital has to pay, and other times the insurance company has to pay. It's always a struggle who has to pay for it, but the people know in the daily practice. Next slide, please. We have lists with products which are to be reimbursed. It is described in the law as a category, not as a product, but as a category. We have the so-called Z-index. It is a private organization who creates this list, but this list is mandatory because health insurance companies are using this list. Issue product not mentioned, it's not reimbursable. Be aware that the distributors of medical devices, it's not so easy to be a distributor because you have to fulfill a lot of things, but okay, they know what to do. Health insurance companies are asking this from the distributors, and it is as it is. And we have many distributors. We have the medical supply shops, we have the pharmacies, we have companies who are selling directly, but that is for reimbursement always a problem. And as said before, health insurance companies making choices because they can choose. I do business with you and not with you. That's possible. They can also make choices in the assortment, what they are willing to reimburse or not. Next slide, please. So they can agree on a budget, on daily prices, monthly prices, annual prices. Everything is possible. And the healthcare provider, they have the contracts, not you as a manufacturer. There are two big ones who are in the market. 80% of the outpatient medical devices are distributed by them, Medic and OneMed. OneMed you probably may know. It is, I think it is owned by a Swedish investment company, well known from the colors of the Ukrainian flag, big warehousings. They are owner of OneMed, IKEA. The smaller medical specialties are almost doesn't exist anymore because Medic and OneMed are the big ones. We know that some manufacturers own a medical specialty shop because they themselves can't contract insurance company, but they bought a medical supply shop who is having the contract with insurance company. So the so-called forwarded integration, but it is quite secret. And that is typical Dutch. Set two Dutch people together and they have a new organization. It's also in the world of the medical devices. Each group of products does have almost an own organization. Suppliers have one, FHI, Federatie het Instrument, but the manufacturers, depending on the products, you have your own manufacturers organization who is lobbying for you and helping you with negotiations and information, etc. So for diabetes, it is DAGNet, is the manufacturers organization. They are also representing the industry in the negotiations with insurance companies, sometimes with the government, with the institutions, etc. And as said, there are many, and they are not working closely together. They are all independent of each other and have their own goals. Makes it very difficult, but for the government, it's a good situation because if you make a deal with one, you can make another deal with the other one, and you can, etc., etc. Okay, that's the Dutch situation. Next slide, please. About medical devices, the outpatient market, you have your market authorization in the middle, your CE. If your product is Me Too, today it's called technical variant, then you are reimbursable at the day you want. If it is a unique product and you have your EBN on the left side, then you are reimbursable. If it is according to the stand van de wetenschap en praktijk, the standard care of daily practice. If you don't have evidence, then you have also some programs to have it still reimbursed. To do that, if the product is still experimental, it is forbidden to pay for the health insurance companies. So it is quite easy. If you have an existing, if you have a product which is to be compared with an existing product, it is reimbursable direct. If it is not is innovative, then you can have all the evidence reimbursable. Not evidence, there are ways to have it still reimbursed. Also quite simple, but you have to know how it works. But there are many ways to have it reimbursed. And next slide, please. And I think that we are now going to France. Yes. Please take the presentation of France now.
And France, should I present the other slides?
Yeah, yes. The one he sent. Are there questions in the meantime for me, or are you all?
Yes, I have one question if I can ask.
Yeah, of course.
This is basically just, is it public, the reimbursement at all? I mean, can I find what hospitals are using a specific procedure or code?
No, the hospitals need to publish the tariffs they charge to patients if they are coming in that hospital. So that are the public prices, but the health insurance companies negotiate with the hospitals about the budget and other prices which are not public. So we suppose that if you see the price list of the hospitals, that 15 to 20% you have to deduct to have the price the insurance companies are paying. So that's the practice. And if you look to the prices of the hospitals which are published, it are often fancy prices because it doesn't make sense. They have to do it according to the law, but nobody uses it because the negotiations are with the health insurance companies and they don't publish the results of the negotiations because health insurance companies are in competition with other health insurance companies and hospitals are in competition with other hospitals. So everybody is having secrets about prices, etc. Dus answering your question, you can find tariffs, but it doesn't make sense.
Right. So actually my question was maybe more specifically, so for example, how many procedures have been performed with this code? Is that kind of...
There are 40,000 procedures, 40,000 codes. And in the system, there is a general information to be found on certain websites, figures from which is invoiced, and the numbers, but it is, I think that 2019, maybe 2020 is to be seen today, but it is to be found on the websites. That kind of information is gathered by the Dutch Health Authority and published.
Okay, very good. Thank you.
Yep.
Sophia, did you also have a question?
No, maybe that was an old hand.
Okay. Thank you.
Frans.
You have to unmute.
Yes, Frans, go ahead.
Well, just in addition to the question of Mr. Naslund, we have indeed a national database which is issued by the Netherlands Healthcare Authority, and that gives a lot of detailed information. We often use that database because it gives information on which doctors use your test or your procedure, what is the volume, how many patients, what is the average price from 2012 till now. So quite often when we do an investigation on behalf of a new product to look at market opportunities, we go into that database to simply look at what are the comparative treatments. Are they being covered by codes? How many people are using these codes? What are the charges, etc., etc. So it's really advisable if you want to enter the Dutch market to have a look at the database for an analysis of comparisons in similar treatment to the indication you use your product for. Anyway, in addition to what Ron was explaining, and his presentation really covered a lot already, I was asked to give some technical specifications on how you actually do the reimbursement process in the Netherlands. So maybe next slide. So the starting point is really an assessment of the innovation potential of a new medical technology, and it's irrespective if this is a medical device or an e-health product or a surgical procedure or whatever. If the technology which is being looked at is not considered an innovation, as Ron was explaining, in principle you can use the existing instrumentarium for products and procedures which are already on the market and being used. So the advantage is that you don't have to go through the procedures which I will outline in a minute, but the disadvantage is of course that the conditions of products which are already on the market for reimbursement will be the same as for your product. And in the Dutch terminology, we call products which are not innovations, we call them technical variants or Me Too products. And if you have a Me Too product, as I said, you don't have to go through what I will explain in a minute. But what you need at least is a report which shows that you have indeed a Me Too product compared to an existing technology. And with that report, you go to a health insurer explaining, well, we have a similar product as a product which you already reimbursed. So this is our report, and please give us the same reimbursement for our product. So if you have a real innovation in the market, then the 2 points which are listed in this slide are relevant. First of all, you need to provide evidence of the effectiveness and use in medical practice, the STWP in Dutch. And this is a procedure which is done by the Dutch Healthcare Institute, the ZIN, which is an advisory agency to our Ministry of Health. And secondly, as Ron was explaining as well, you need a payment code because even if you have your product in the system, because it is compliant with STWP, you still need to have a payment code. Otherwise, you can't reimburse, you can't invoice your product. So next slide. So what does it mean, this STWP? We have two elements there. It's on the one hand, the proof of effectiveness, and the other element is the use in medical practice. So the proof of effectiveness implies a number of steps which should be in your dossier. First of all, there needs to be a proof of therapeutic value, clinical effectiveness and side effects. Secondly, you need to have a budget impact analysis showing what the net costs or benefits are to the Dutch healthcare insurance system. You need to do a cost effectiveness analysis. You need to have an expression of the burden of disease, not only in terms of the epidemiology of the whole indication you want to treat, but also effects of your treatment on quality of life. In fact, this quality of life is an important element in the approach because we have seen many dossiers which were submitted to the ZIN for evaluation of STWP, and somehow the quality of life was missing, and then the dossiers were simply not considered by the ZIN, and in fact they were handed back to the submitting party, asking them to provide quality of life data after the fact. And then an important element is the medical technology, a useful addition to the package, and that means is it really necessary for the health insurance to cover this, or can the patient pay himself or herself, or are there already similar services and benefits in the package which really obviate the need to add this new element to the system. So next slide. Now I put up this slide simply to explain to you that the way the ZIN looks at this STWP clinical effectiveness issues is really very much in conformity with evidence-based medicine. Evidence-based medicine is the applied practice in most Western European and North American markets. So that means that if you collect clinical data from Sweden, you can present it according to the same rules as you would do that in Sweden. And a very central tenet of the application in the Netherlands would be the formulation of the so-called PICO. And this is really an extremely crucial element of the whole approach, because we have seen many examples where the PICO was not well defined, and I will give you some examples in a minute. Well, PICO stands, of course, for the patient population, for the indication you're treating, your intervention against the comparator, which is usually the standard care or the usual treatment care, and then the outcomes subdivided in pivotal outcomes and secondary outcomes, and the timeline. And the examples we have seen where the evaluation of the STWP was really difficult was because there were arguments about the outcomes. We have seen, for instance, that the manufacturer wanted to put quality of life outcomes as secondary outputs, whereas the ZIN felt quality of life should be a pivotal outcome. Well, the difference is if it's a pivotal outcome and there's something wrong with it, then the whole dossier is not approved. And if it's a secondary outcome and something is wrong with it, then still under conditions the dossier can be approved. And similarly, we've seen difficult issues with establishing the comparator, where there were differences in opinion between the ZIN and the manufacturer of what the comparator should be. And this is especially applying to, for instance, surgical procedures involving quite complicated technical issues. So extremely important to define the PICO and to reach agreement with the ZIN at an early stage what should be in the PICO and what not, because if there is a disagreement, then the chances of getting the dossier approved are really slim, or getting slimmer the larger the differences are. So next one. Now, another key concept from evidence-based medicine is this MCID concept, the minimal clinically important difference. And this is more or less related to the PICO, because the minimally important differences is the difference in clinical effects of the intervention and the comparator. And why is this MCID is so important? Because based on this MCID, the sample size of the number of patients to be included and to be reviewed by clinical research is decided. So it is not a difficult conclusion to say that if there are problems with the comparator and it's unclear how this MCID should be calculated, then the dossier which you submit based on that is bound to fail. So this PICO and this MCID are definitely the two key concepts of EBM, evidence-based medicine, which are utilized by our authorities. So the next one. Now, what's apart from the PICO and the MCID it's very important to look at the level of evidence. Now, for the level of evidence, our authorities use a specific methodology, And according to that methodology, and this is probably the same in Sweden, RCTs, randomized controlled trials, are the gold standard. And what the ZIN would like to see is a comparison of the intervention to standard treatment in a selected indication defined by the PICO. And what is important, they would like to see head-to-head comparisons. However, head-to-head comparisons are quite often problematic because many manufacturers don't want to compare head-to-head with a competitor because they are afraid that this will show that their product may not be superior to the direct comparator. So many clinical trials compare an intervention to placebo, but according to the ZIN, what is also acceptable is an indirect comparison in a dossier where the interventional studies comparing to placebo are compared to the standard treatment clinical studies comparing to placebo. And then it's really important to draw up what the ZIN calls the indirect comparative tables based on, again, the PICO and the main clinical trials. Now, if RCTs are not available, then other study types are also admissible, such as observational studies, cohort studies, or real-world evidence. And we see more and more, especially in studies with longer-term perspective, that cohort and RWE studies are the mainstay of the data input, and these are in fact acceptable. What is not acceptable are studies which are reported by means of abstracts in scientific meetings or presentations by key opinion leaders or physicians at scientific meetings. But what we also see is that, and this is what we do quite often, is that we organize key opinion leader meetings focusing on a Delphi a consensus approach, where we try to arrange semi-academic outcomes of these meetings, which are quite often acceptable for the ZIN. So RCTs are the mainstay. Other studies also acceptable. Consensus meetings, which, by the way, are also a nice way to introduce a new product in a country like the Netherlands, also acceptable. So next slide. Now, just very briefly, because it's 2:45 already, I mentioned clinical effectiveness as an important input in a dossier. Economic effectiveness, also clearly important. 2 levels, the budget impact analysis, estimating the financial consequences of adopting a new intervention, and then the financial consequences at the level of the payer. Methodologically, what we quite often do is that we develop one model, one economic model, for instance, a Markov model or a decision tree, and use that approach in first instance to calculate the budget impact, and then at the second stage, the cost effectiveness of the technology, the cost effectiveness being looking at the cost in relation to the health benefits, expressing the technology by means of a cost per quality adjusted life year, for instance. Okay, next one. Now, in terms of how you do these economic studies, the Netherlands was one of the first countries in Europe which issued cost effectiveness guidelines. Our guidelines are, in fact, from 1998, so they are more than 20 years old, 24. And I think in Europe we have a couple of countries which are really advanced in having defined these cost effectiveness guidelines, except apart from the Netherlands, it's the UK, of course, but Sweden is also one of the countries which has done a lot of work. So that means that cost-effectiveness studies which have been done in Sweden, and we've seen many examples of those studies, we can usually use them in the Netherlands as well, although we have to make some modifications because we need Dutch costings and we can't use Swedish costings. Okay, next slide. Now, the second element of this STWP is this use in medical practice. And that has become, over the last few years, more and more an important input for the ZIN. In a sense that the Dutch medical practice, they must have been introduced to a technology, a medtech technology, before the ZIN will start evaluating the reimbursability. However, a few years ago, it was okay if a couple of hospitals used the technology and they wrote a letter to the ZIN that they liked the technology and they would ask the ZIN to start evaluation. But nowadays, the system has a little bit changed because the professional medical societies have to be involved at an early stage. And they, in fact, before the ZIN starts the evaluation of the technology, they should inform the ZIN that the use of the technology is that they are in agreement with the evaluation by the ZIN. Now, the strongest level of acceptance of a new medtech is, of course, adoption in a medical guideline. But this is a little bit unrealistic to ask from a technology which has just been introduced, because introduction in a medical guideline usually takes a long time and is never a procedure before the fact, but always after the fact. As I said, the medical professional organizations, they must now inform the ZIN before they start with the evaluation. And what is also important is that this advice from these medical professional organizations is usually a competitive process. And you have to imagine that in any given year, 5 or 6 or 10 new medtechs are approaching a medical society, and we have a lot of experience with the Dutch Heart Foundation, for instance, or the Dutch Foundation of Cardiologists. Sorry, the Dutch Heart Foundation is the patient organization. And then these organizations, they cannot report to the ZIN on all these technologies that they find with the starting the evaluation procedure. So they have to make a selection. And few of these medical professional organizations, they have in fact set up procedures to select the technologies for advising positively about to the ZIN. And these professional organizations, they look at issues like how many Dutch hospitals have used the technology, what is the epidemiology of the disease, how many patients are there, is it an expensive technology given the constraints in the healthcare budget, all those type of issues. And what we have seen in practice, and we have examples of this, is that small medtech companies, for instance, in the cardiology field, they have real difficulties in getting through at these professional organizations compared to these big medtech companies who have big budgets and they can introduce their new technology in many Dutch hospitals at the same time. The patient organizations were mentioned as well by Ron. Patient organizations also have to give positive advice to the ZIN to look at a new medtech technology. But what we see in practice is that if the professional medical organizations are in favor, then usually the patient organizations will also be positive as well. Okay, next one, and that is in fact the last one. Now, how much time is in fact involved in arranging all these processes? Our advice is always start at an early stage, as early as you can, even if you don't have all the clinical data available, but you have promising clinical trials in the wrap-up stage or even earlier. And the reason is, of course, that it really takes a lot of time to arrange this proof of clinical evaluation and use in medical practice. First of all, you need to start massaging a professional medical organization, as well as a patient organization. But as I said, patient organization is less difficult. And to get on the roll of this internal evaluation procedure of a professional medical organization takes some time. The procedure takes time, so 12 to 18 months is about average. And then the dossier itself, the technical preparation, and we do a lot of these dossiers every year. It takes about 3 months on average. It's a lot of information which goes into these dossiers on clinical, economic, well, all the issues I mentioned. When you submit the dossier to the ZIN, it doesn't automatically mean that they will start reviewing it. We have seen cases of some delay because of shortages of personnel starting the evaluation. And sometimes they have procedural questions and they check the dossier if it's complete and all these type of issues. But from the moment they have clarified that they will start the evaluation, it takes 6 to 9 months. And I must say, we do these dossiers as well in Belgium, for instance. The Dutch organization, ZIN, they stick to the timeline. So it's usually more like 6 months than like 9 months. And then the outcome will be an advice to the Minister of Health to include the medtech in the statutory benefit scheme. And that, of course, the minister has to put his signature and inscribe the product in the list. And that takes a couple of months. But in principle, as of the moment, the ZIN gives a positive advice. So that is after the 6 months. The Dutch patients, they have a right to the product. And so even if it's not officially reimbursed, if a patient has the knowledge that the ZIN made a positive advice at a certain date, they can approach their health insurance and say, well, this benefit is now available, please give it to me. By law, the insurer has to provide it. The only difficulty, of course, is that there is no official reimbursement yet, and that needs to be arranged. But we have seen examples where patients actually proceeded like that, and they actually got the benefit. So the final message I want to give you is that the Dutch system is quite fair. I think it's of technically of quite a high level. It's, in our opinion, the way the ZIN looks at clinical and other data is by and large according to the rules of the game of doing clinical research and proper methodology. Of course, there are always differences of opinion, but usually when we submit a dossier, we manage to get it approved. And our theory is that the way to approach this is to reduce the marginal space the evaluator has time and again. So if they have some kind of a problem, then you resolve it in an appropriate manner, and that means they can't go back to that same problem. And in working like that, the margin of free room of the regulator becomes smaller and smaller until at the end of the day they have very little room left, and then they approve the dossier. Okay, thanks.
Thank you very much, Frans, and both Ron and Frans. Now I can tell that you really needed the 2 hours because this was very helpful. But as there's just a few minutes left of the this session, I'll open up for questions from the audience. Do we have any direct questions? No, I should look in this direction.
And also,
Yes,
I'm sure
maybe.
that, oh yeah, okay, go ahead.
Short question here. So basically, if there is a reimbursement code for example, the fiducial markers that I'm representing here, but we feel that's the standard product, but we have one which is much more clinically beneficial with lower risks, etc. If we would like to get a higher reimbursement for that product, we would basically just have to go through all the process you described to establish new code, basically.
Yeah, correct.
Yeah.
Unless you think, well, we don't want to invest this 2 year and all these efforts, and we want to settle for the lower reimbursement of the test, which may or may not be the same as yours, and you don't agree with the clinical outcome of the reference test, but just for the sake of getting your reimbursement arranged quickly, you settle for the conditions of the test, which is already reimbursed. But I wouldn't do that because it hits you in the end if you go for a technical variant solution in the Netherlands, whereas in Germany you want to get a reimbursement as a unique product. Because we have seen examples where the German regulator, they speak to the Dutch regulator, and if the German regulator then finds out that in the Netherlands you get reimbursed as a technical variant, then your dossier in Germany is bound to fail.
Mm-hmm.
It sounds like tough business. That it's really, everyone is, the insurance companies are even negotiating in India. I mean, that's in my world,
Yes.
5 steps ahead.
So all these regulators, they talk to each other, and I can say that for historical reasons, the standing of Swedish companies and the Swedish procedures of reimbursement and approach, they're very highly regarded in the Netherlands. So it's almost as if you are a Swedish company, you have an advantageous starting point in the Netherlands. The same applies, by the way, to Danish companies, Norwegian companies, and all the Nordics have an advantage here.
That's good to know. But if you start out as a technical variant and you add some new, you develop the product, can you then apply for a new code, or is it no? You're already.
Yeah, but yes, that is possible. But then, on the basis that you have a completely new product, not on the basis that you have a similar product with some adaptations.
Okay, so you can't go back on that decision. You have to make a good decision from the start then.
Yes, it's either or. It's not and.
Yeah.
So we're already at 3 p.m. For people who have to leave the meetings, I will send out the contact details to Ron and Frans. because I'm sure that you will probably need to hold hand with someone on the Dutch market. We will have a third seminar on May 31st with the Netherlands Foreign Investment Agency. Probably not this detailed and in depth. So if there's, you know, questions in regards to how your specific company can get support, I highly recommend Frans and Ron as your contact people. We will also talk with Ron and Frans about an upcoming maybe a delegation trip in the fall. We're now thinking of beginning of October. And we'll sort of, appreciate your input if there's specific, areas that you want us to focus on. I mean, just listening to all these different stakeholders to keep in mind and be in contact with and be aware of and everything. I'm sure we will need great support. But do we have any?
First of all, just to let us know if you're interested in a delegation trip or not, and then we'll have discussion on what aspects you would like to have covered.
Okay,